Welcome to the deep dive. You're here because you want to get a solid handle on pediatric migraines, and that's exactly what we're aiming for today.
Yeah,
We're not getting bogged down in, overly complex stuff. Our mission is really to pull out the key insights from pediatric migraine revision notes,
exactly.
giving you a clearer, practical understanding of these headaches in kids.
We've sort of distilled it all down. Think of this as your streamlined guide to
Right.
what really matters with migraines in children.
Great. So let's dive right in then. Pediatric migraines are incredibly common, right? Like the most frequent primary headache for kids.
That's right. They are the most common, and they can really disrupt a child's life.
And it's important to remember they can show up differently in kids compared to adults.
Yes, absolutely. That's a key takeaway.
Yeah.
Okay, so to get us started, what exactly is a pediatric migraine?
Good question. Let's define it.
Okay, so at its core, a migraine is a common brain condition. It leads to these recurrent headaches, usually moderate to severe. They often feel sort of pulsating, maybe on one side of the head. But here's the interesting thing in children.
What's that?
Well, we actually see them reporting pain on both sides of the head more often than adults do.
Oh, okay. So not necessarily the classic one-sided thing we hear about.
Exactly. In kids, think bilateral more often. That's a really key thing to remember if you're trying to figure out if it's just a regular headache or maybe a migraine in a child.
Both sides more often, that's a really important distinction. And it's not just the head pain itself, is it? There are other symptoms too.
Absolutely. Yeah, these headaches, they kind of come with a package deal. Other symptoms are usually involved.
Okay.
And duration-wise, in kids, we're typically talking episodes lasting anywhere from, say, 30 minutes right up to 48 hours.
30 minutes. That can be quite short.
It can be, yes. Shorter than the typical adult duration,
Ah.
often. And we also have different categories, different classifications of migraine that are particularly relevant for children.
Such as? Which ones are most important for us to, keep in mind?
Well, you've got migraine without aura that's pretty common in kids and adults.
Okay.
Then there's migraine with aura. And this one has various subtypes, like aura without the headache actually following, or hemiplegic migraine, things like that.
Right.
And what's really fascinating here are the childhood periodic syndromes.
What are those?
Things like cyclical vomiting, abdominal migraine, and benign paroxysmal vertigo. These can actually be early signs or sort of precursors to developing migraines later.
Wow. Okay. So they might not even present as headaches initially.
Sometimes, yes.
Mm.
We also see retinal migraine, more common in younger people, probable migraine, and of course, potential complications.
Okay. So quite a wide range of ways these can manifest. Now, let's talk about what sets this whole process off. What's the cause, the etiology?
Yeah, the precise cause isn't fully understood, which, can be a bit frustrating.
For sure.
But the current thinking is it's down to this complex interplay between a child's genes, their environment, and various neurochemical factors in their brain.
So a mix of things.
A mix of things, exactly. Think of it like a unique combination coming together in that child. These factors are thought to lead to, well, abnormal activity in the brain and changes in the brain's blood vessels.
So it's not just one single thing we can point to.
Nope, precisely. It's a combination.
And are there specific things that might make a child more prone? What are the key risk factors we should be aware of?
Yes, definitely several important ones. The biggest one, really, and often the most telling, is family history.
Ah, genetics.
Huge factor. If a parent or sibling has migraines, that significantly bumps up the child's chances.
Yeah. What else?
Hormonal changes can play a role, though this might become more relevant as they hit adolescence.
Right.
Then you have things like certain foods or food additives. These can be very individual.
Sugars, yeah.
Triggers like stress, definitely. Not getting enough sleep, inadequate sleep is a big one. Exposure to strong sensory stuff like bright lights, loud noises. And sometimes certain medications can contribute too.
So a lot of potential pieces in that puzzle. Now, if we could zoom in a bit on what's actually happening during a migraine attack, what's a pathophysiology? What's going on inside?
It involves these complex neurovascular processes. What seems to happen is activation of the trigeminal nerve pathways.
Okay, the trigeminal nerve.
Yeah, and this activation leads to the release of these tiny chemical messengers in the brain, neuropeptides.
Neuropeptides, right?
And they then cause inflammation, basically, in the blood vessels around the brain.
Inflammation.
Yeah, and this whole cascade results in changing the brain's blood flow and the levels of neurotransmitters, the chemicals brain cells use to talk to each other. It's kind of a domino effect, starting with that nerve activation.
A chain reaction in the brain, it sounds like. Okay.
Mhm.
Now, when a child comes in with a headache, how do doctors tell if it's a migraine or something else? What's the differential diagnosis?
That's a critical question, absolutely. We need to think about other common types of headaches,
Like what?
like um, tension-type headaches often feel like a tight band, you know?
Mm.
Cluster headaches, which are really severe and come in cycles, sinus headaches, often with nasal symptoms,
Mm-hmm.
and importantly, medication overuse headaches.
Oh, right. Taking too much pain medicine.
Exactly.
Yeah.
Can happen in kids too, unfortunately.
And are there any specific warning signs, any red flags that should immediately make someone think, okay, this needs a closer look, maybe urgently?
Absolutely. And knowing these red flags is vital for you.
Okay, what are they?
So if a child has a headache that wakes them up at night, that's a worry. Or one that's there first thing in the morning upon waking,
Right.
a headache that just keeps getting progressively worse over time, that needs checking out.
Makes sense.
Also, if it's triggered or made worse by things like coughing, sneezing, or even just bending down, that's a red flag.
Okay.
Headaches with a fever and signs of meningism like a stiff neck, light sensitivity, definitely concerning.
Yeah.
Vomiting with a headache, especially if it's bad or persistent. Headache with ataxia that's like lack of coordination or any change in their consciousness level, super serious.
Definitely.
A headache starting within 5 days of a head injury needs prompt evaluation.
Right.
And lastly, a headache that comes with a new squint or they have trouble looking upwards, sometimes called sunsetting eyes. That's a critical sign. Any of these really warrant specialist assessment.
Those are really crucial to keep in mind. Thank you. Are there any other medical conditions that seem to pop up more often in kids with migraines? Associated diseases?
Yeah, it's interesting. Research suggests that children and adults, too, with migraines might have a slightly higher chance of also having conditions like asthma, allergies, motion sickness.
Yes, motion sickness. Interesting.
Yeah, and even seizure disorders. The exact link isn't totally clear, but there might be some shared underlying sort of sensitivities or maybe inflammatory processes involved.
Interesting connections. So, how common are migraines in kids here in the UK? What's the epidemiology look like?
They are indeed quite common in the UK, a significant impact on population health.
Right.
While overall migraines are more common in females, with onset often later, it's important to know that chronic migraine does affect some children and adolescents.
Okay.
And like we said, that family history is very, very common in kids who get them.
So, definitely a significant health issue. Now, let's really paint a picture of what it looks like. What are the typical clinical features when a child has a migraine?
Okay, so recapping a bit, recurrent headaches, moderate to severe intensity, usually lasting between what we said, 30 minutes and 48 hours for kids.
Right, 30 minutes to 48 hours.
Often comes with nausea, maybe vomiting.
Yeah.
And that sensitivity to light and sound is pretty classic.
Stegophobia and phonophobia.
Exactly. And remember, location often frontotemporal, so front and temples, and more often bilateral in kids compared to adults. That's key.
Got it. And what about when a child experiences an aura? What kinds of things might they notice?
Yeah, migraine with aura. This can present with a whole range of temporary neurological symptoms. They usually happen just before or sometimes during the headache.
Okay.
Most common are visual disturbances, seeing flashing lights, zigzag lines, maybe blind spots.
Visual stuff.
But it can also be sensory things like tingling or numbness, sometimes motor problems like temporary weakness on one side.
Weakness. Wow.
Yeah. Or difficulties with speech or language, even changes in thinking or concentration. It's quite varied.
It sounds like the aura itself can be pretty diverse. And you mentioned some different types of migraines earlier, variants.
Yes, there are specific migraine variants, things like hemiplegic migraine, which involves that temporary one-sided weakness we just mentioned.
Okay.
Basilar migraine symptoms seem to come from the brainstem, maybe dizziness, double vision. Ophthalmoplegic migraine affects eye muscles. And acute confusional migraine, which can cause, well, confusion and agitation temporarily. Each has its own unique features.
Complex. And those childhood periodic syndromes we touched on, how do they fit in again?
Right, things like cyclical vomiting, these recurrent severe vomiting episodes without a clear cause.
Right.
Or abdominal migraine, intense episodes of stomach pain. And benign paroxysmal vertigo, sudden brief attacks of dizziness.
Okay.
These are thought to be related sort of on the migraine spectrum. They can sometimes be precursors to developing typical migraine headaches later, and they often need a specialist referral for diagnosis and management.
So it's not always just a headache. It can be stomach pain, vomiting, dizziness first.
Exactly. And again, family history of migraine is often there in these cases too.
Okay. And you mentioned phases of a migraine attack.
Yes, understanding the phases can help recognize and manage them.
Mhm.
There could be premonitory
Or
symptoms.
the headache.
Yeah, hours or even a day or two before.
Mm.
Might be changes in mood, energy, appetite, subtle clues.
Okay.
Then obviously the headache phase itself,
Mm.
followed by the associated symptoms, nausea, sensitivities, and finally the post-trum phase. That's after the headache stops, where the child might feel really tired, washed out, weak, maybe some lingering mild symptoms.
The migraine hangover.
Kind of, yeah. That's a good way to put it.
Okay, so we have a much better picture now of what it is, the causes, how it looks, what's next, how are they actually diagnosed? Lots of tests involved usually.
Well, interestingly, for most cases of straightforward pediatric migraine, brain imaging, like an MRI or CT scan, is generally not needed.
Oh, really?
Yeah, unless there are atypical features or, importantly, any of those red flag symptoms we talked about earlier.
Okay, so no routine scans. What about blood tests?
Similar story. Routine labs are usually unnecessary unless there's something specific in the child's overall picture that raises concern.
So how is it diagnosed then, primarily?
It really relies heavily on getting a detailed history. A good account of the headaches, frequency, duration, symptoms, triggers, combined with a thorough physical and neurological exam. That's usually enough.
History is key.
Absolutely.
Mhm.
But we would consider further investigations like imaging if the neuroexam is abnormal persistent weakness, say, or papilledema, which is swelling of the optic nerve.
Right.
Or if there's a history of seizures, significant head trauma recently, or a big unexplained change in their usual headache pattern, then you investigate further.
That makes sense. Investigate when things seem unusual or worrying. Okay, so once a pediatric migraine is diagnosed, what's the plan? How do we manage them?
Right, management. It involves two main arms, really. Acute treatment for when an attack happens to relieve pain and symptoms,
Okay.
and preventative treatment, or prophylaxis, to try and reduce how often or how severe the attacks are in certain cases.
Got it. Let's start with acute management. What works best?
So for acute attacks, it's worth noting that ibuprofen might actually be more effective than paracetamol for some kids with migraine.
Ibuprofen over paracetamol. Good tip.
Yeah. For older kids, age 12 and up, triptan medications can be an option. Specifically, sumatriptan nasal spray is licensed.
Nasal spray, okay.
But it's really important to remember that the oral triptan tablets aren't generally licensed for under 18s. Needs specialist input usually.
Right. Age matters for medication choice. What else helps during an attack?
Well, alongside medication, non-drug strategies are vital. Simple things like resting in a quiet, dark room, cool compress on the forehead can feel good.
Mm-hmm.
And identifying and trying to avoid known triggers is, well, crucial long-term, but also helps manage acute episodes sometimes.
Okay. So first steps for an attack.
First line, for mild or early attacks,
Mm.
simple pain relief like paracetamol or, as we said, maybe ibuprofen.
Right.
If there's nausea or vomiting, antiemetics can be really helpful, things like domperidone or prochlorperazine.
Okay.
If those simple measures don't cut it, that's when a specialist might consider triptans, like the nasal spray for over 12.
And anything to avoid.
Yes, ergot alkaloids. They're an older class of migraine drugs, generally should be avoided in children.
Good to know. Okay, what about preventing them? Prophylaxis, when is that considered?
Preventative treatment might be looked at if a child's having really frequent or severe attacks that are significantly messing with their life.
Like missing lots of school.
Exactly. Impacting school, social activities, quality of life. But it's important. Prophylaxis is used in addition to acute treatments, not instead of them.
Right, you still need something for breakthrough attacks.
Precisely. Some medications that might be considered are propranolol, topiramate, or pisotofin.
Okay.
Though it's worth saying the evidence for how well these work specifically in children is a bit limited compared to adults. So it's a careful decision.
Individual basis, weighing things up. Got it.
Hmm.
When should parents or GPs definitely think about referral to a specialist?
Okay, referral guidance. Urgent referral, maybe even hospital admission, if you suspect a serious underlying cause, one of those red flags, or if a child has status migrainosis.
Which is?
That's a really severe, relentless migraine attack lasting over 72 hours. Needs urgent attention.
Wow, okay.
You'd also consider referral if there are complications, if the diagnosis isn't crystal clear, if the current treatments just aren't working well, or if you think preventative treatment is needed.
Right. And beyond the meds, what other general things help?
Just providing clear explanations and reassurance to the child and their parents is huge. Demystifying it helps a lot.
Yeah, reducing anxiety.
Definitely. You're helping them identify and manage potential triggers like we discussed,
Right.
establishing consistent daily routines, regular sleep, meals.
Lifestyle stuff.
Yeah, and behavioral strategies can be great too. Relaxation techniques, maybe biofeedback sometimes.
This is a lot of great information. Maybe a bit much to remember all at once. Is there a handy way to recall the key management points?
Yes, actually. Mnemonic could work. How about triggered?
Triggered. Okay. Intriguing. Walk us through that one.
Sure. So T is for triggers, identify and manage them.
All right.
R is for rest, adequate sleep generally, and rest during an attack.
Got it.
I is for ibuprofen, paracetamol, first line pain relief options.
Mm.
First G is for general measures, reassurance, routines, lifestyle.
Makes sense.
Second G is for guidance for referral, knowing when to get specialist help.
Crucial.
E is for education for the child and family about the condition.
Yes.
And D is for diet and sleep, maintaining those healthy habits. Triggered.
Triggered. That's actually really helpful. Okay, let's try and apply it. Quick scenario. A 10-year-old comes in, recurring headaches, mainly frontal, lasting about 6 hours, often feels nauseous. What's the most likely first step for acute management?
Based on what we've said, most likely initial acute management would be to try ibuprofen.
Ibuprofen.
Yeah, given it might be more effective than paracetamol for migraine in kids, and it's a good first-line choice for a moderate attack like that sounds.
Great. Okay, so looking ahead, what's the long-term outlook, the prognosis for kids with migraines?
Fortunately, while it can be chronic for some, the overall prognosis is generally pretty good with proper management.
That's good to hear.
Yeah, and it's quite encouraging, spontaneous remission, where the migraines just resolve on their own, happens after puberty in about half of affected kids.
Half. That's quite a lot.
It is. Although migraines starting in adolescence might be a bit more likely to stick around into adulthood.
Okay, that's reassuring overall, though. And what about complications? Are there serious ones to worry about?
Serious complications are generally rare, thankfully,
Phew.
but we absolutely have to acknowledge the impact. Frequent or severe migraines can really take a toll on a child's daily life, their schooling, their social life, their overall quality of life.
Yeah, the functional impact.
Exactly. And we need to be mindful of medication overuse headache, like we mentioned. Using acute pain meds too often can backfire and cause more headaches.
Right, tricky cycle. So serious issues are uncommon, but the day-to-day impact and medication management are really important.
Precisely.
Well, this has been a fantastic, really thorough deep dive into pediatric migraines. Just to quickly wrap up the key points. They're common. They have some unique features in kids, like being bilateral more often manageable. But recognizing those red flags is vital, and diagnosis really hinges on a good history.
Absolutely. We hope this conversation has given you, our listener, a much clearer, more practical handle on pediatric migraines. Hopefully you feel better equipped to recognize them and think about the next steps.
Definitely. And for those of you who want to solidify this knowledge even further, maybe test yourself, do check out passthemsra.com. Lots of in-depth revision stuff and practice questions there.
And don't forget, a free resource is available over at freemsra.com too. Always worth a look.
Absolutely. So, maybe a final thought to leave you with. Considering how much migraines can impact a child's life, school, friendships, everything, what role do you think schools and maybe the wider community could play in better supporting these kids and their families?
Yeah, that's a really important question. Definitely something worth mulling over. How can we create more supportive environments? Good food for thought.